Vamsi,
Yes, sir.
Selvaraj sir has joined, so we can start the program. I think let Selvaraj sir address the delegates.
Good evening to all. Welcome you all to this webinar, OASIS ICL, hosted by KOA. So today's theme is complications in hand surgery and lessons learned. So first, our OASIS president, Dr. Selvaraj, will do the welcome address. Dr. Selvaraj, sir, go ahead.
Yeah, am I audible?
Yes, sir, you're audible.
Yeah. Good evening. Respected Secretary General of OASIS, Dr. Aneen, the President of KOA, the Secretary General of KOA. It's happy to note that you have organized the CME on complications of hand surgery and the lessons learned. Because if you always keep presenting a rosy figure, the youngsters tend to think that every surgery is going to be simple and straightforward. Unless they are aware of what complications have happened and how the experts have tackled it, it's very, very difficult for the youngsters to understand the nuances and the complications, and then how to tackle the complications. I'm sure you got a good panel of experts to deal with the problem. I wish the program all success, and I'm happy to inaugurate the CME. Thank you.
Thank you, sir. Thank you, Dr. Selvaraj, sir. Prof. Aneen, Kutty, are you here? Bharat, sir, I think you're muted. Not able to hear you.
Aneen sir is having trouble joining. He's trying to join. Vamsi.
Dr. Nithyanand, sir, here? Is Dr. Nithyanand here?
He said that he's joining.
Sure.
Dr. Aneen is here.
Yes.
Dr. Aneen sir.
Yes. Selvaraj sir has spoken. Sorry.
Yeah. So
Aneen, we are waiting to hear from you.
Sorry for the delay. I just found out the faculty. Hi. Good evening, everybody. Respected President of OASIS, Selvaraj sir. Karnataka Orthopaedic Association office bearers and dear friends, it's a great honor to have this ICL every month. We are getting good crowds every month, and I think this time Karnataka has taken a lot of pains to conduct this in hand surgery, and I thank Dr. Bharat for all the efforts he has taken. And let's not delay the academic feast. Let's go on. Thank you all.
Thank you, Dr. Aneen, sir. Nithyanand, sir, can you share a few words before we go ahead?
Good evening to all. Can you all hear me?
Yes, sir, we can hear you.
Yeah, good evening to all. It's a great opportunity for Karnataka Orthopaedic Association to have this opportunity to conduct this hand program of OASIS ICL. So I thank Dr. Selvaraj, Dr. Aneen, and our KOA President, Dr. Ashwini, and our Secretary, the most dynamic Secretary of KOA now, Dr. Bharat, and for Dr. Sathya Vamsi for taking pains to organize a very good faculty. And I wish the program all success. And over to you, Dr. Vamsi.
Thank you, Dr. Nithyanand, sir. Dr. Ashwini Kumar, sir, is a current president of KOA. He's going to share his thoughts on this webinar.
Good evening, everyone. Good evening to all. On behalf of Karnataka Orthopaedic Association, I just welcome all of you. And Dr. Sathya Krishna is doing a wonderful job. He is conducting a webinar today, and I wish him all the best. At the same time, I request all of you to be I request all of you to log in and take the benefit of this webinar. Thank you all.
Thank you, sir. So I thank the OASIS office bearer for giving KON the opportunity to organize this webinar. So special thanks to Dr. Nithyanand Rao, Dr. Ashwini Kumar Singh, and Dr. Bharat to allocate this monthly webinar to hand surgery. So we are fortunate to have experienced faculty with us this evening to share their knowledge learned through years of training. Our theme for today is complications in hand surgery. Some of us will present few of our own complications and of course other complicated cases presented to us. So redo surgery is a task both for the patient as well as the surgeon. Nobody wants to go wrong the second time. So in the panel, we have 4 senior faculty. First is Dr. Binu P. Thomas. He's a HOD and professor of hand surgery unit at CMC Vellore. The hand unit is named after Dr. Paul Brand. So the hand unit there is the first of its kind in our country. He carries the legacy of great surgeons like Dr. Paul Brand, Dr. Selva Pandian, and Dr. George Anderson. I'm fortunate to be trained under him, and many of our today's faculty are his students. So he started the first MCH hand surgery program in our country. So Dr. Binu has described various techniques in hand surgery. I welcome you, sir. And Dr. Anil Bhat is from KMC Manipal, Associate Dean and Professor, and Head of the Hand Surgery Unit. Dr. Anil is a well-known and a popular speaker, sought out by most of the Orthopedic Association nationally and internationally. He has inspired many orthopedic residents to seek hand surgery as a career. He represents and holds office in AO Hand North America and ASSH. Dr. Anil's department has recently started MCS hand surgery at KMC Manipal. It's the first of its kind in Karnataka. Not only is very active in research, he's also taken initiative to help others write research papers. I welcome you, sir. Dr. Praveen, sir, is he here? Dr. Praveen Bharadwaj is a consultant. He's not here. He's a consultant from Ganga Hospital, and he's an asset to the Ganga Hospital. He is constantly seen teaching or operating. And Dr. Praveen Bharadwaj has recently been appointed as editor at JHS AP. It's a proud moment for all of us. I was also lucky to be trained under him for 6 months. And we have Dr. Srinivas Rajappa. He's a HOD of hand surgery at Sri Ramchandra Medical College, Chennai. He's also trained in CMC Vellore, Ganga, and NUS Singapore. Dr. Rajappa also runs the MCH program at this institute and runs numerous cadaver courses on hand surgery. I welcome you, sir. So today we have 3 HODs of MCH hand surgery program. I hope in near future, all the colleges will run MCH program. So I start with my presentation, and I will introduce the other faculty just before their presentations. So I shall be addressing my questions to the panelists. The other faculty can interrupt or give their opinion if required. So I will go into my first. So I have 2 cases. I'll be presenting one case first, and depending on the time, we'll go to the second case, or I can come back later for the second case. So the first case was actually operated by one of our senior residents first, and then it came to me. So he's a 20-year-old gentleman. He was a delivered born. He presented with a road traffic accident. So this was his initial X-rays on presentation. It's a closed fracture. So Dr. Srinivas Rajappa, are you here? Hello? Srinivas, sir, are you here?
Yeah.
Yes, sir. I think, can you see the X-ray, sir?
Yes, I can. Yes.
Yes, sir. This is a closed fracture. So I want you to comment on the X-ray. How do you diagnose? What is the diagnosis, clinical? Diagnosis, and what will be your management options? Is the X-ray seen well, sir? Rajappa sir, are you there? Are you able to see it? So I think trouble correcting.
Connection.
Dr. Anil sir, you want to Dr. Anil sir, you want to take up this X-ray. So what is a remarkable things you see, and how do you plan to manage this if it was your case?
Is this dominant hand or is it
non-dominant hand? Non-dominant hand.
Okay, young fellow, 20-year-old.
20-year-old.
So I see both the bones fractured at the distal third. I also see distal radial ulnar joint disruption there with the widening of the DRUJ space. Do you have a forearm X-ray, full length forearm X-ray?
No, sir, I don't have, but nothing is in the elbow.
Okay. So ideally, I would prefer to have a full-length forearm with the elbow and wrist as a single film, especially in these cases, to see if there is any issues in the proximal radial ulnar joint also. So if it was a classical distal third radius like this with DRUJ, we would have told it's the Galeazzi, but this also has a ulnar shaft, probably some combination there. So it's a variant of Galeazzi, which has been described quite recently. So on examination, I would be also looking for any kind of swelling and compartment syndrome if he is presenting acutely, but otherwise it's basically a Galeazzi variant.
Okay. So how do you manage this, sir? Like, how do you plan to fix this in order of fixation?
So basically, you need to get back the DRUJ back to its original position and maintain the length of the forearm bones. So open reduction internal fixation is a must. That is a basic principle. And then check what is the status of the DRUJ and see whether it requires an additional fixation or just immobilization, depending on how stable it is. So it's almost kind of halfway through, like in Essex low Presti, where you expect a lot of soft tissue injuries also in terms of sometimes even the intraosseous membrane. So we need to see how stable the DRUJ is after the fixation of both the bones, and then take a decision on the DRUJ management.
So you mean to say if it's stable, you leave it, immobilize it, and if it's unstable, you go for a repair of the TFCC?
Not really become aggressive on TFCC repair, but at least immobilize it. See in what position it is quite stable. I might transfix with a K-wire, or I might at least put an elbow kind of immobilize slab and immobilize. But basically what you need to understand is to give enough time for the soft tissues to heal here. It's not just the fracture. So there's no role for early mobilization as such, but those soft tissues at the distal part, TFCC, intraosseous membrane, preventer quadratus, all these secondary stabilizers have to heal. So at least 3 to 4 weeks of immobilization would be good enough for the patient. Yeah.
Thank you, sir. So this is we can call this as
Vamsi.
Sorry.
Vamsi.
Hello? Yeah, who's?
Srinivasan here.
Oh, sorry, we lost you. So I went on to Dr.
Yes. Just to say that I'm around.
Okay, thank you. So actually, this was done by resident, senior resident. So, Dr.
Can I make one comment? Can I interrupt you?
Yeah, sorry. Please go ahead, sir. Yeah.
If you look at that X-ray, I think that the styloid is also avulsed off. No, that your pre-op X-ray, the styloid appears to have come off there and lying more proximally next to the radius. So definitely, it's a very major injury to the DRUJ.
So what you would say, definitely it requires some kind of TFCC fixation. Is that what you're saying, Dr. Bino?
I mean, I would go more for that because with the styloid coming off like that, it's definitely that the whole TFCC is attached to that. And I mean, like Anil said, you can test the stability after anatomical fixation and make sure there is no rotations and test the stability. And if the styloid is remaining separately, I would even primarily think of putting a K-wire through the styloid, or even more rigid fixation of the styloid fracture. I would consider that.
Thank you, Dr. Bino. So let's show you what is the. So this is, of course, as Dr. Anil said, this can be labeled as a fracture variant of Galeazzi. This was described by Mimic to add this that variant. And so this was an immediate post-op X-ray after the fixation. Dr. Praveen sir is here or is that to join? Dr. Binu, what do you think? Are you satisfied with the fixation? What do you think is right or wrong?
That's a difficult question to answer. But I mean, if you are being very critical, I think the fixation, there is some, the ulna is probably could have been done better. And there is a shortening, ulna is long relative to that. And then again, as I said, the styloid fragment is not there. At least I cannot see that. But I would go with the same thing with the stabilizing the DRUJ. And
okay, so but apart from the ulnar fixation and
on the lateral view, if that's a true lateral, I think the ulna is still subluxed again. So
what do you
think, I can see,
why do you think the ulna is still subluxed?
There can be two reasons. One is there is a rotation which has not been addressed, or the second, an angulation, and then if you had supinated it and then fixed it after reducing the joint, then it would have been probably better.
Okay. So this after the cable removal, this is what has happened. The ulna seems to be kind of uniting, but the ulna is still subluxed dorsally. So Dr. Anil, what do you suggest be done from now onwards?
So this is 6 weeks post-op. K-wire is off. DRUJ is disrupted still. The ulna is comminuted. I mean, that is a basic thing. The ulnar fixation is an important part, including the styloid, as Binu was telling, but the length basically comes from the ulna. And so that is where I said comminution was there. So that was probably and definitely inadequate kind of fixation. If you see the number of screws on the plate itself, it's not adequate to hold that comminution. It requires a longer plate. That is first thing. Second, of course, was that the DRUJ probably was never addressed in the sense that it was not reduced. As Binu again said, you need to check it in all planes and see at what best position it is reducing, and that is a position it needs to be reduced. And so probably it is a massive injury, so probably there could be even an impaction, or rather, some soft tissue interposition also. That ulnar styloid displaced fracture again. So probably the surgeon couldn't get complete reduction of the DRUJ. So it has probably gone to a stage of impaction where it is not coming back there. And so primarily, I would have, not hesitate to open up the DRUJ and check what is hindering the reduction. Not assuming that it's just an angulation. It could be that there could be a massive soft tissue interposition there and basically gone into irreducibility. So these are the three things we need to think at this stage, why it does not come back and what best can be done at this point of time to reduce it, because this DRUJ will definitely give problem to the patient in terms of restriction of chronosupination. And eventually a young patient obviously would, depending on his work and everything, will have major disability.
Yeah. Okay. So you are saying that we have to look for the interposition and try to get the ulnar right.
I mean, that is the basic teaching even for Galeazzi also. When we fix Galeazzi, we assume. I mean, we always think that automatically DRUJ falls back, and most of the time it does fall back. So you have to look on the image and see what's happened, and then check. And if it is not, the same basic teaching happens in both Galeazzi and Montegia. So if it is not reducing back, we need to always check what is the reason. And one of the common reason would be that interposition of soft tissues. And in this patient, in this kind of a variant, as I said, there are three major structures. One is TFCC, second is interosseous membrane, third is a pronator quadratus. So all these three things have to be checked here. And also sometimes the ECU also, the subsheath of the ECU. So something should be holding it. Or it's just that if you look at the interosseous space also, even in the previous X-ray, if you can go back, it's not formed back nicely. You don't have that long oval shape of the interosseous membrane formed back, which means there is a problem with the parallelogram kind of effect you need to get back once you fix the bones. So that is missing there.
Yes, thank you. So as you see, he has got a limitation of supination. His main complaint was supination and palmar flexion. So sorry, I just missed one slide. So now it's been 4 months. I think he's not briefed for the surgery. So Dr. Srinivas, my question is, once you get back the ulna straight, do you plan to reconstruct the TFCC with some kind of a reconstruction like palmaris longus, or would you just correct the ulna? Dr. Srinivasan, are you here?
Can you hear me?
Yeah, I can hear you, sir.
Okay, great. Just a couple of points. Dr. Vinu made a mention of the ulnar styloid. I think the ulnar styloid is maybe of secondary importance here. I think the attachment of the TFCC to the fovea is the one which gives the stability to the DIUJ. So I would not concentrate too much on the ulnar styloid, but I would maybe concentrate on a foveal insertion if I was doing it primarily. But going back to the present situation, yes, I think I would redo the ulna. I think it's got a volar apex angulation, which is leading to a sort of the ulna head is that I think is the primary problem in the DIUJ now. So once I correct the volar apex angulation, I get the ulna head back into the sigmoid notch. If it stays, there's a good chance that it will still stay. I don't think there's a great deal of soft tissue interposition in this patient. But I would redo the ulna. If it stays in place, then I'd leave it. I'm not a big fan of the Adams-Berger operation because I think it replaces a tendon in place of a ligament. And I think, biologically, physiologically, it's not a great operation. At the end of the Adams-Berger operation, if you see them 4 or 5 years down the line, there's still a lot of play on the DIUJ. So my choice here would be correct the ulna, then fix the TFCC. I think you still see a stump there, and then see what happens.
Thank you, Dr. Srinivas. So as I said,
Vamsi, any further imaging was done for this patient?
No, sir, no, we haven't got any MRI or CT. Nothing else was done.
I still, it's worthwhile to do some advanced imaging at this stage instead of being speculative about what is injured and what is not. So that before planning for a resurgery for the patient, we need to have more information as to what's happened to the soft tissues. Is it just a bony geometrical problem of the forearm bones, or is it something related to soft tissues also? I think with that information, we'll be more, clear as to how we can proceed.
I think difficult to do an MRI on this patient, isn't it, Anil? He's got a metal plate there. It's about 6 weeks.
Absolutely not. So absolutely not. There are enough algorithms we can, yes.
Do you do it in Manipal?
Yes. Okay. As long as they're titanium plates and it can be done. There's absolutely
was this a titanium plate?
No, it's a steel plate.
So what's the option now?
So basically, go ahead.
I would still image in terms of at least I have somebody who can do a good ultrasound and see some soft tissue information. I would still get. So I would still get an ultrasound and see what's happening with the soft tissues. But yes, if it was a titanium plate, the correct way should have been an MR for this patient.
Okay. So
let me add a comment. I think here, even if you correct the ulna, which is primarily the problem, that even if you correct the ulna, I think here you have to explore and see about the TFCC because you don't have a third chance. So make sure that whatever soft tissue, it's likely that there is some soft tissue interposition also. So you may need to fix the TFCC back. And this is your second chance, is probably the best chance you're going to get from now, because otherwise you're looking at one of these Adamberg procedures or something later.
Can I add something?
Yeah, please, Dr. Darshan.
Definitely, this one we need to open up, I feel, even because the 4 months duration, the capsule would have all changed the anatomy. So you have to open, you have to correct. The most important is correct the angulation. Anatomic reduction is important. And at the same time, we need to, because just by reducing even the anatomical reduction, I don't think the ulna will go in its place, because the capsule 4 months time, definitely they would have. Even if not an Adamberger, capsule double plication or imbrication also can help, but provided we correct the ulna. Without correcting ulna, anything we do, I don't think it will help. And imaging, I don't know how much really will add on to the situation, because as it is, I intend to, whether irrespective of it, you have to open the DRUJ joint there to get it corrected.
Yeah, so I'll just say what I did. Actually, I did similar to the line what we all discussed. I wanted to get the ulna right first, so I changed the plate dorsally to get it straight. You can see these are the previous holes, the normal holes. And TFCC, I did try to repair. It's all scarred, degenerated, and I couldn't hardly find a good space. But since you see the distal, the ulna was almost completely denuded. So I was worried that, going for a TFCC reconstruction would cause more problem on the ulna vascularity. So I just corrected only the ulna. And I used 2 KYs to transfix the DRUJ. I immobilized him for 6 weeks. And this is at 4 months from the surgery. And you see now he's got his complete supination. So I was thinking that if it's still unstable, I'll come back for DRUJ reconstruction later. But he seemed to be doing well. So does anybody have any comments on this?
I think that's an excellent result, Vamsi, for a complex problem.
So what I've learned is that, of course, TFCC is a key factor, but there are other important ligaments around the DRUJ, like what's the DOB ligament. That can be tensioned or stressed only when you maintain the both bones curvature. So the main problem was the loss of the bones curvature. Once we are able to restore it, we are able to tension the central band interosseous membrane and the DOB, and that provided the stability is what I feel. So that's the end of my first case. Anybody wants to comment anything, or anything could have been done better?
No, I think the key was Darshan, go ahead. Sorry.
Yeah, no, it was very good, very nicely done. And this very often we find this problem of, even in simple ulnar fractures or radius fracture, they miss out the slightest of angulation. Improper reduction causes these type of issues. And then eventually they present us after a year or something. Then we end up doing salvage procedures like Savu Kapanje or something. It's a nice case and it was done well. However, I would have always tried to open up this part as well. But here you could manage to get the reduction exactly on the, without opening on the DRUJ part. You have opened up, I guess, only till TFCC, not on this DRUJ joint, I guess the images what you showed. It looked like that. Yeah, but you have got the reduction. So the job is done. So.
Okay. Thank you. So I just stopped my presentation.
Just one question to all the senior faculty. Like if we played the ulna so distally, the hardware going so distally, inevitably we have to open up the ECU tendon and everything. So do you routinely recommend again stabilizing the tendon, or just you leave it like what Vamsi has shown, that it was totally out of the sheath?
What do you mean by stabilizing, Dr. Sunil?
It means ECU reconstruction. Do you reconstruct the ECU sheath?
Once the plate goes so much distally, inevitably the ECU is out of its sheath now.
What it means is this one. The ECU is lying outside.
Repairing the sheath, or are you talking about some other?
Yeah, some other reconstruction or anything. Do you recommend it, or you can just leave the tendon bare open like that?
I think you basically lift off the entire tissue of the ulna, right? So you're not really going and disrupting the subsheath. So you're not entering that area at all, in the sense that you don't dissect through the subsheath. You're lifting everything off the periosteum. It all falls back there only. And I think why it is stable now is basically, I think, because Vamsi didn't go and open that area. And so that secondary is capsular contracture in a way is actually stabilizing this entire thing, even though TFCC is not repaired there. And what I told in your second X-ray, Vamsi, that is the most critical thing, where you need to see that forearm space, what has happened to it. Once the fixation is over, primary fixation is over, that interosseous space, that long oval has to be checked, and that is completely disrupted in your second X-ray. So that is the key to the whole thing. That means all the soft tissues are under perfect tension. and the anatomy is absolutely good. So all our both bones, when we do, that is what we need to check in our check X-rays.
Thank you. So I think I will overshot my time. So we'll go with the next presentation by Dr. Darshan. And if time permits, I'll come back to my second case. It's my own complication. So Dr. Darshan, you can start sharing your screen. So Dr. Darshan Kumar, most of you know, is a busy hand surgeon from Bangalore. He runs a hand surgery and orthopedic clinic in Bangalore. So he has several publications and authored. Am I audible? Yeah, he's authored many publications and chapters on hand surgery in various books and journals. And he has conducted a lot of wrist arthroscopy workshops on surgical approaches and brachial plexus at Vamaya. So he's going to present a case on open elbow injuries. Dr. Darshan, you can go ahead.
Thank you very much. Thanks, OASIS and Vamsi, for this opportunity. So basically, this presentation is on open elbow injury. So a 28-year-old male who underwent a two-wheeler accident to his right elbow present is after the injury. Initially, an X-fix was applied in another hospital. And actually, rather than we removed it immediately is the wrong way, because he came to the OPD and our residents were seeing it. The X-fix literally came to their hand. So I don't have a photo of that. So an open elbow injury, and he had a composite tissue loss when we saw the wound. So it was like a bone, ligament, and this were the images. The X-fix was very precariously applied. So they just literally came to our resident's hand. So he was 2 days later, he presented to us and unable to extend his fingers. A closer look of the wound, you can see the lateral condyle on this. A radial head, and the shaved off the part of the radial head is also missing. X-ray showed, this is how the X-ray was. So we made a diagnosis of open elbow injury, unstable elbow, composite tissue loss over the lateral aspect of the elbow with lateral condyle and ligamentous attachment loss as well. How do we proceed? Vamsi, do you want to moderate this or guide this anything, or anybody wants to please?
No, I think it's best if you ask any individual consultant opinions. Dr. Anil, sir, you want to start?
Anyone wants to go back on these images and have a look at it, and any more information you want on this?
Do you have any CT scan done to look at the distal humerus elbow loss?
No, I don't have any CT. I did not, because it was so clear, means the image was like this, so I did not get it done CT.
Any primary procedure done, because he came after 48 hours?
So yeah, there was an X-fix actually. There was an X-fix which was just loosely. There was one pin was just, means, as I told, our residents just tried to do a dressing and the X-fix came to their hand. Okay. It was like namesake. It was not really doing any job.
Was it debrided primarily?
The OT notes mentioned like that, but the wound was like this.
Okay. So obviously you see that it's still contaminated, and you see the secondary zone of injury also all the way at the distal arm and
forearm.
And the forearm also, proximal arm and distal forearm also. So we need to be careful about that. We need to also look at if there's any degloving kind of injury, secondary degloving, which will happen in these patients. Plus, of course, we know that there is a gross ligamentous instability, and the PIN is involved in this patient because patient is not able to extend his fingers. So primarily requires a debridement, a thorough debridement, and I would not put an X-fix. Obviously, it's the lateral instability can be maintained with a slab, but basically start off with a good debridement and see what structures are damaged. And radial head looks reasonably okay. Clinical picture, there is some amount of, I think, cartilaginous loss, right?
Yeah, the condyle, the one almost 25 to 30% of the radial head is also shaved off along with.
Also shaved off.
Yeah, okay. This X-ray also. X-ray may not be, but this condyle almost. So that surface was gone.
Was gone. Okay, right. So I would wait for the wound to get clean. And then think of a reconstruction as a secondary procedure. And so there are two major things. One is the instability. First is, of course, the coverage of the elbow itself. Second is the instability. Third is the nerve injury. So three major problems we see in this patient, and we need to tackle it one by one. The primary focus is always obviously to not get it infected. So a thorough debridement and stabilization with whatever means, and then plan for a early coverage as soon as possible because the joint is exposed. And then we think of a reconstruction for the nerve in terms of if there is a major loss of the tissue itself, and because it's a PIN which branches off so quickly, probably I would think of secondary reconstruction later. Okay. That would be the initial plan. Yes.
Anybody else?
I think I also will go with that. Maybe only difference is maybe because it's already 2 days old. It's very potentially infected. So what do you do? Is it I would consider a whack, and then wait for a few days, get a pus culture and everything, and then go for a flap cover. And your first thing to do is to cover the defect.
Okay. And how would you address the bony instability? Any plans for that? Because that was because I would cover it, but eventually end up with a very grossly unstable it was. So any plans for that? Because how do I get that stable? Even if I cover it, if it is not, elbow is not stable, how do I, other than slab, I agree totally, but anything else in the long run with such a condylar loss, you will have any?
Both the ligament and nerve reconstruction in any of the ways would obviously require a clean environment. So both for a ligamentous reconstruction and also the nerve reconstruction, either with tendon transfer that which happens more distally, but otherwise even the primary or rather secondary ligament reconstruction would require a good coverage for you to do that.
Okay.
I think in this case, a thick ulnohumeral pin should give enough stability for us to take care of the soft tissue part, including the flap. And once this wire is out by around 3 to 4 weeks, the anterior capsule and everything heals back. And ultimately, we may not need a lateral ligament reconstruction at all. So if we have a good stability and reduction on day one with a good cover, isolated lateral injuries usually don't cause much of a trouble unless you have a lot of articular surface loss.
Okay.
So Neil,
there are two things which I want to say. Yeah, I was about to say about ulnohumeral pin. I don't know. I have never applied, and I have seen enough number of problems with these trans elbow pins, whether it's ulnohumeral or radiohumeral or this thing. I have encountered good number of problems. What others have done, I hardly use it. I want your opinion on.
I'm saying for open fractures, not for closed dislocations.
Can I say
all the more one, Sunil, where you have. As Binu was telling, it's 2 day old, and for all the infection would have started. You wouldn't want to violate the joint again with a foreign body, especially with a K wire, which has chance of a pin track, plus infection getting in, plus breakage, and so many other complications which we see with that. Yeah.
Can I add something,
please?
I am not against using an ulnohumeral pin here. Somehow, I think there is some pressure on all of us as specialists when we say ulnohumeral pin. Ulnohumeral pin is taken off as a typical general orthopedic operation, but I think it's still a good buy. I would still do what Sunil suggested. I would put an ulnohumeral pin, maybe supplement it with an external fixator, and then do the soft tissue part. My experience has been there at the end of the whole thing, this elbow ends up being stiff. If it gets so much movement that the lateral ulnar collateral ligament problem manifests, then the first thing I do is get myself an ice cream, because I managed to get so much movement of this elbow that the instability is manifesting. Now, this is akin to you have an anterior cruciate ligament problem in an osteoarthritic. Knees are not unstable, right? They are stiff. So similarly, my problem in all these big injuries, the injury is a lot more than some of the individual injuries. So my problem has been that they have all ended up with stiffness.
Ajeesh,
in spite of the fact... Sorry?
Rajesh. Casualty mein kahan rakha hai?
Vamsi. You didn't mute. Parcel mein like
Moderator is a culprit.
Hello?
It's a part of the meeting. Still take it.
Oh, sorry, I was calling.
No problem. It's okay. That's fine.
Yeah.
Vamsi, don't mute it. It's still okay.
No, he was keep calling me from Pasmana. Okay.
Yeah.
Don't worry. So my point is, ulnohumeral wire is okay, but provided the wound is clean, get the soft tissue part. If the elbow is unstable, first ice cream, then ligament reconstruction.
Okay, I agree with your Srinivas one point, but elbow becomes stiff because of our immobilization duration, nothing but that. It's only the duration of immobilization which causes stiff, or else we can get it.
See, suppose you put a flap on it, Darshan. How fast do you mobilize this elbow?
3 weeks.
So it's the same thing we do, right?
Okay.
I just want you to fasten up, Dr. Darshan.
Okay, next. Okay. So these were the problems as we discussed. This was an open injury, unstable elbow. Options was debridement. That's a common denominator there. Stabilization, again, was when was this soft tissue cover. We discussed on all this. Mobilization. So this was the debridement I did. So this was, you can see the radial head part which was seen there. Then that was the lateral ulnar collateral and the annular ligament there. So luckily some bit was still there. And that was a posterior interosseous nerve. I was lucky there as well. So, and I did like what Dr. Binu suggested. After the debridement, the wound reasonably looked okay. So debridement and VAC was the first thing I did. I did not go for any stabilization at that time. I did in second stage everything in one go. That's a local flap with anconeus flap I did and SSG. That is what was, I repaired the lateral ulnar collateral ligament with an anchor, LUCL. I did a local flap, then finally covered it with a skin graft also. So 1 week, this is how the wound was. 3 weeks, 1 year. So he had some amount of difficulty in getting his finger straight. 1 year follow-up. That's the range of movement. And this was his X-ray.
What was done for PN? What was done for PN?
I told you it was lucky. I was lucky there. It was there. PN was there. There was there's some muscle tissue which was lost. Actually, that's why he had a little bit delay in regaining his. This image was. You can see in this image the PN was there.
So,
PN was all the way. I identified it. Yes.
So Darshan, you should get a big tub of ice cream from Rajappa first.
Okay, now the ice cream is, suppose you had decided to do the LUCL reconstruction. Yeah. Now, luckily you found a stub of the LUCL there, so you were able to get it right. So that's a damn good idea. But in case you didn't find that LUCL, in my opinion, to reconstruct it with the tendon graft is a bit of an overkill.
I would still, because such gross, I agree with sometimes, so many times it becomes stiff and ends up, but lateral side gives more problem than medial side. If it were to be medial side, I would have ignored, but lateral side really, especially whenever they do, means away from the activities, away from this thing, it generally tends to give a lot of trouble on the lateral side. Medial side, we can get away so many times, unless they try to load their elbow. So I would definitely try to reconstruct if that time, lateral side especially.
It all depends on what is the finding after the wound heals and how unstable it is, and that is when you take a decision on that. With the amount of, if there was no LCL there, LUCL, as you were saying, you were lucky and you found the stump there. If it was not there, with that amount of articular surface shearing there, and if there was absolutely no ligament there, you should always basically take a decision based on the patient's disability and instability, both. And then take a decision on reconstruction or leave it alone. If it's become stiff enough, then leave it alone. That's how we should probably decide.
Darshan,
I have a question.
Go ahead.
Yeah. You're lucky that you just got away with the skin so judiciously. But in case if you had needed a flap cover in this case, then how would you immobilize your elbow, and what would be the choice of flap for this?
If a flap had to go over the olecranon or much more posterior, means depends on whether you require a local flap or a free flap. Typically, I would prefer to do a free flap in these, if at all, if much more of this thing, LD would have been the most preferred one, which if I had to do, if the degloving, because his degloving luckily was not more on the proximal as well. Distally, he had degloving. A smaller defect, even a reverse radial artery, there are multiple of options depending on the size of the defect, I would say. And if it were to rest on the elbow itself, like the olecranon itself, then I would have definitely gone with an X-fix. If the flap doesn't have to rest on an olecranon, then even with the slab, I could manage this.
So this patient was lucky that his capitulum was intact. Imagine if the capitulum, there was a loss in capitulum of around 30%. What would
no, he had significant loss. Actually, it means even though he had that much loss, but luckily that part means the other part I could push it there, and he had a concentric loss of the radius head as well. So
no, I mean, suppose you had a significant loss, what would have been your
capitulum? I have no idea. That's why I asked you. I mean, I have no idea if at all if I had this thing. It's very.
We did have a lot of patients, but I didn't know what to do. Like any senior faculty can comment on that.
Okay, now can I say something here?
Yeah, please.
The cornerstone of the elbow, as far as the flexion extension movement is concerned, is the ulnohumeral articulation.
Okay.
If you have a bad capitulum, that's worse than no capitulum, because at some point of time, you need to have a.
We lost you. Are you there? Dr. Shyam, I think you're using your phone. I think the network is fluctuating.
Yeah.
So you basically need one of the radial head is obviously the stabilizing factor, a bony stabilizing factor, and then you have the LUCL. So if you don't have the capitulum, if the radial is intact, then it's fine. I mean, it's like radial head excision. We're doing on the opposite side.
So you leave the X-fix for longer so that it becomes stiff. That's all I guess you need to do.
No. What I'm saying is you reconstruct the LUCL and also put a radial head prosthesis, and then the capitulum, if it is not there, don't worry about that. That's all. So you need to give the lateral support. So both bony and ligamentous support. So that's
just
what
I got cut off for a bit. What did you do for the? Was there an instability? Sorry, I missed that part.
Yeah. He had this thing. You want me to? So this is what.
No. Just tell me only. You don't need to go back and all.
No, I repaired the LUCL in the second stage itself.
Okay.
Oh, so you put I put a VAC as you planned. So. So I repaired that this thing because that stump was there. Small stump was here on this part.
Okay. All right.
So
okay. Got
I repaired that. So.
Sure.
Finally, that I could get.
Okay, great.
Another doubt, if you luckily you got to get away with the pin intact, and probably the initial presentation you didn't have a finger.
Sorry, Gopinath, its voice is breaking. Your internet is not.
Yeah, probably because of the muscle loss in the starting stage you didn't have a finger extension, but because the pin was intact, gradually after full healing you had the extension.
Yeah.
But what if, with the muscle loss, you had a lot of loss of the nerve also? Would you go with the nerve reconstruction before your flap, or would you wait later and later do a tendon transfer later?
No, if I had found the nerve and that's this thing I would have done. I tried to combine as many procedures as the second stage. With the flap itself, I would try to finish off those as well.
Because the pin usually at this stage, when it branches out, it almost gives away many branches, and probably getting the distal end may be very difficult because.
No, that's what it all depends. That's why I explored the nerve. I saw it was continuous. I saw there was some muscle loss also, and even though they were weak, I told them we need to wait. You let us wait and see. Let us not do anything for this at present. If it doesn't recover, I would have done a tendon transfer at a later. But the nerve was so continuous, so I just left it.
Thank you, Dr. Darshan. I think we're out of time.
Yes.
So, Suneel, you're next. So, Suneel, I want you to present any one of your best cases. whichever you like. So Dr. Suneel is working as a consultant hand and peripheral nerve surgeon at Medicover Hospital, Madhapur in Hyderabad. So he did his medical school from Kakatiya Medical College, Warangal, and MS Ortho from Osmania Medical College, Hyderabad. After that, he pursued his training in hand and microsurgery at CMC Vellore. He was my senior fellow at CMC Vellore. So welcome, Dr. Suneel. You can go ahead with your presentation. One case. Dr. Suneel, you can go ahead. Suneel, your audio is doesn't seem to be working. Are you there?
Yeah. Can you hear me now?
Yeah, I can hear you.
Yeah. So this is a case of a 20-year-old male.
Oh, full screen.
Yeah, just coming up. So he had a history of fall and outstretched hand 1 year back, and this was his dominant hand. This was his present picture. He presented with a 1-year-old scaphoid non-union, slightly into the proximal pole. And as a routine, this was his MRI. And MR shows a hypointensity on the T1 weight, suggestive of avascular necrosis. So my question would be to Dr. Praveen, sir.
I'm not sure his joint. I couldn't see him. He's here. Yeah, he's here. Dr. Praveen, sir.
Dr. Praveen, how would you take this MRI and what would be your plan for this?
Praveen is here.
Yes, yeah. Thank you.
Hello, sir. Welcome.
I'm very much here, Vamsi. I'm listening everything.
Okay. I wanted you to be in. You were silent for a long time.
Yeah. So actually, at 1 year, even if MRI is showing avascular necrosis, and I think many times MRI people are very over-diagnosing avascular necrosis. So this case, I don't think there is avascular necrosis. There is some amount of whitish in the proximal pole over there.
Yeah.
And that black part that is just because of the edema of the near to the injury site, it would look like that. So many times the radiologist would overdiagnose that it is an AVN. But in either of the case, I think this size of the bone is quite big enough for fixation, and it does not require any vascularized graft. So we would open it on the volar side and do a fixation. And bone graft, depending on how much is the cavity inside. So if it is having a lot of cavitation here, we would put a olecranon strut graft and fill all around with the cancellous bone graft. But if this is not like a cavity and there is a good amount of straight bone contact, then I will straight away put a corticocancellous bone graft from the iliac crest.
So upon opening volarly, if you find that there is no punctate bleeding in the proximal pole, would your plan change at the instant, or would you still go ahead?
It will not change. I think still we will go ahead with the same bone graft.
Okay. In this case, I prefer to go dorsally because this was slightly towards the proximal pole and there was no bleeding. So I had to, this was one of my earliest cases. I had to go with the vascularized bone grafting, and this was a fixation. There was a large cavity left over after curating to healthy bone. And the complication here is that this is at 3 months. Fracture is all healing well. You find some spurring here on both sides. Now, what happens at 1 year follow-up is he comes with very painfully restricted wrist movements. And there are like a lesion extending right from radius onto the scaphoid, both of them kissing each other. And I went ahead with a CT scan to know what exactly is wrong. And this is the picture. So has anyone faced something of this sort, and how would you manage this? Binu sir, what would be your take on this?
So there's definitely now radiostyloid, styloscaphoid arthritis also there, I suppose. Was that a remnant of your bone graft, or is it an arthritis?
This looked to me like when we take the vascularized bone graft, I took too much of periosteum with the graft to save the pedicle.
And that
got calcified.
It's too early in a year to develop so much of arthritis.
Yes.
So here your fracture is united as far as the CT is concerned. So here one thing would be to consider a radial styloidectomy and excision of that osteophyte kind of this thing, and see how good the movement and the pain would be before you plan for any other salvage procedures, I would consider. And I have seen this kind of protuberance on the scaphoid after a iliac crest bone grafting, and where we actually did the radial styloidectomy and excised that osteophyte dorsally, and it did work.
Yes, this patient was actually an adolescent around 19 years, so that thick periosteum must have added to this insult. And I had done exactly what you had suggested, so removed that bump and did a radial styloidectomy. And this was his well-united scaphoid with a reasonably well-preserved wrist movements at 1 year. And I'll just swiftly go to the second case.
Suneel, can you go to that X-ray once, previous one? The next slide. Next slide.
The post-op.
No, the one later on.
Sorry.
Just before that. Just before this. Yeah.
Okay.
See, your Zedenberg graft is still having such a big hole in the radius. Is it common to not heal and not get filled up? Go to the next slide to them.
This CT shows a huge cavity here.
Where we don't want so much bone is forming, here nothing is forming.
In fact, I had a bad experience. We tried to put some bone substitute into that area, and then later that came up and the tendon got ruptured with the bone substitute. So we stopped doing that. I would rather see a picture like this rather than put bone substitutes to where you've taken a bone graft.
Thank you, sir.
It's quite often these areas don't fill up actually. It's quite often it is seen like, it means whenever we do this, it's quite often those areas don't seem. I have noticed that.
Anil, sir,
how many of you are doing these vascular grafts for scaphoid non-unions and AVNs especially? And because I remember Praveen sir telling me when I was a fellow that long-term results of even non-vascularized just impaction grafting is as equivalent as vascularized grafting. Praveen sir, can you please?
I would still tell the same, Gopi. Actually, when Dr. Suneel had asked me opinion, I had told a non-vascularized graft only. Yes. So I think this size of the bone in the scaphoid, it is not avascular. If it is a very proximal pole fracture, then is the only place where we put this Zedenberg graft. Otherwise, we don't put vascularized graft. And all the big meta-analysis, all studies, actually Dr. Ajeesh, in one of our journal club, he presented a paper by Scott Wolf, and they have reviewed all the literature of whichever is published related to vascularized, non-vascularized graft. And they found that the vascularized graft is actually really not required except for a patient where you are doing a failed non-union surgery. So that was the only proper indication they put. Otherwise, even there are papers which say MRI proved avascular necrosis and simple bone graft put and they have united. And union rate is almost same as what is reported by a vascularized graft.
I think you need to prove as a hand surgeon, you need to do vascularized bone graft.
Can I make a comment here?
Yeah, Ajeesh.
Dr. Suneel, yes. Dr. Suneel, do you have a pre-op CT by any chance? Just to clarify that part.
No, sir. No pre-op CT.
No, okay. The pre-op X-ray?
Yeah, this is a pre-op X-ray.
Yeah, so one interesting thing about this was when I was with Dr. Tirkanath there. So this sort of an X-ray, he would actually, what he used to do was to go by a dorsal approach like you have chosen, but then he would not open the fracture site at all. So if there is not too much of a deformity on either the MRI or a CT scan, what he would do is an in situ fixation. So first do a drill hole, and then once the drill hole is through, then he would take a distal radius bone graft, pack it into that drill hole, and then just put the screw through that. It was an in situ fixation technique when there was no deformity in the scaphoid. And actually he had great results. And the whole logic was that you would not disturb the
stable
writing side at all, disturb the fracture side at all. And that's something that I have also tried over the few cases. which came, which did not have a deformity, and they actually seem to work well. So then again, the debate on whether you need a vascularized bone graft becomes doubtful, because when these simpler things seem to be working equally well, then probably there would not be a need for a more complex procedure like a vascularized bone graft.
And can I come in?
Yes, sir, definitely.
Yeah. So the basic premise of all of us assuming that there's an AVN is the MRI itself. And that itself is wrong, because the MRI is basically picking up some stage of AVN, right? So if somebody says it's AVN, that itself is wrong, unless you put everything together, the duration, the quality of the bone, the punctate bleeding, then the signal intensities in both T1, T2, everything you put together, and then also visualize the cartilage status when you open up. You need to put all these factors together for you to consider whether you will go for a salvage, or you will go for vascularized graft, or you would just put a cancellous graft and a fixation. So our basic understanding of AVN itself is, based on so many assumptions. And so it's a spectrum of, where is there ischemia and infarction, and finally avascular necrosis, and finally infarction. So this is the spectrum what we see. And once we understand that, then only we can talk about all these. Otherwise, till then, it's always speculative. But my only worry is in this patient, the amount of styloidectomy you have done. So was it stable enough for the radiocarpal?
It was stable, so I didn't want to take any chance. So I had to overdo it a bit.
And the cartilage was good?
It was all good. The radiolunate articulation was all fine.
Okay, great.
So Anil sir, I'll just briskly go through this. This case is for you. This is a 4-month-old fixation done elsewhere. This patient presented to me with this complication. Now, this was the initial X-ray, preoperative. It communicated minimally displaced fracture and indication for surgery. And this is at 4 months post-op. There are no immediate intraoperative or postoperative X-rays available. What do you think would have gone wrong, and how would you salvage this now?
This for me, Sunil?
Any one of you can take, sir. Binu sir, go ahead with this.
Obviously, the screw is not where it should be.
Yes.
And what about this is the initial X-ray also? Immediate
this
pre-op?
Is directly at
post-op?
4 months, sir. There is no intervening X-ray. This is a pre-op and 4 months post-op. That's all.
Okay. I mean,
we don't know how it was inserted.
Cannulated screws are really famous for being put in various angles. So you can't say that it didn't have a central placement, first of all. I think so it may have been initially itself wrongly put. The only thing is when a fixation, if it fails, one thing that always comes to my mind is whether there is a transcaphoid perilunate injury. That is the only thing I would always check when it comes with a fixation like this, where the screw is going in a different direction. So these are the two things I would consider, and but I don't see any obvious features to suggest a perilunate injury here.
Yes.
So it may be just a fixation has gone wrong also.
Another factor you have to look is also infection in these patients. But if you see the distal pole, hardly there's any bone left there, and the screw is cut through that, and obviously it was a volar entry there, and only the proximal pole I can see, at least whatever I can see from the X-ray here, and there is some amount of the loose body. I mean, rather the fragments of bone there. So infection is one thing you should always rule out in these patients, like any trauma patient coming with this kind of implant failures.
So in this case, I went ahead with a CT scan to see where exactly is the screw and what's the status of scaphoid. So the entire distal pole of the scaphoid was fragmented. The proximal pole was there, but there's a lucency inside. So probably the screw has cut through that proximal pole, and the hardware lying all around the joint. And now, Anil sir, looking at this picture, with no signs of infection, inflammatory markers were normal, no signs of any clinical suggestive of infection as well. What would you do at this? Do you think it is salvageable now?
We can salvage the wrist, we can't salvage the scaphoid, I think. So obviously the screw has to come out there. We need to check what's the status of the proximal pole, its integrity with the scapholunate joint itself. So you can just leave it alone as a distal pole excision. It can work like that. A lot of times it can still work as long as it's stable and the screw is off, and you can have the integrity of the SL joint perfect. And then when you screen the joint and it's quite stable, you just leave it. And that's the minimum thing you can do. But you can do so many other things also, like you can completely take away the scaphoidectomy, and you can do a limited fusion based on, again, cartilage status and everything. So both ways it can go. Praveen would probably bat for PRC if you push him harder, but otherwise, basically try to do the minimum possible and keep all the rest of the soft tissues intact. I think it's just 4 months old, right?
Yes, 4 months.
Yeah. So I would still want to keep the wrist as stable as possible. So if the distal articulation is completely gone, just remove everything, all the loose bodies there, fragments, the implant, and check the SL status, and then be done with it. If otherwise, then if there is any instability, then maybe scaphoidectomy, and the cartilage is also damaged, scaphoidectomy, and I would go for maybe a capital unit kind of fusion.
Can I add that?
Sir, Sunil, in the X-rays, it was looking as if distal part and proximal part is available. See, CT scan sometimes may be misguiding because it is giving at just that level how is the bone. I think X-ray is more useful. Your X-ray showed as if good amount of distal pole is there here.
No, sir. Distal pole looks all fragmented.
Yeah, okay.
Proximal is good, but distal I'm not sure.
I saw this X-ray, sorry. Correct, yeah. This looks like gone.
I think the mistake or the error here was to put this screw. You see, this was a screw which I retrieved from
this patient, sorry?
He's 35, police personnel, and this is a dominant hand.
So here the capitate looks like as if it started subsiding also. It's coming closer to the
translation.
radius.
Yeah, totally.
Yeah, so I think, PRC is a good option. Otherwise,
capital lunate fusion.
Yeah, capital lunate fusion if you can get it back in position. And being a policeman,
better do PRC.
Needs a strong wrist. What about a four corner fusion? That's also would be in my mind. Or is it an overdue?
I think PRC is good, sir. For 35.
PRC is good. I agree with you, Praveen. Absolutely. PRC is good.
Yes, the thing is that this patient actually had a TFCC reconstruction done on the other side by me 2 years back. And now he came with this injury on this side. So, and he was a police personnel. He wanted to do all this heavy work. And I was a student of Binu sir, and I went ahead with four corner fusion. I think it depends on where you are trained from.
Sir, Sunil sir, can I ask a question, sir?
Yeah.
Sir, it looks like a type 2 lunate.
Yes.
So
exactly.
Anything that is causing the problem to do, the capitate is more of coming to the scapholunate region. So even lunocapitate fusion is also very difficult, I think. Recently I faced it. So there intraoperatively, I cannot mobilize the lunate to the capitate to fuse it. So I went and had to a PRC. So anything the type 2 lunate is causing the problem here?
No, here the problem is entirely because of the hardware failure and fixation failure.
Now that is okay, sir. Now the next step, anything the type 2 lunate will decide to do a 4-corner fusion or PRC.
I agree, yeah. It's good.
Yeah, I think PRC or 4CF is a personal choice, what we recommend to the patient rather than the patient's demands. Right. And whether we do a capital lunate fusion or a 4-corner fusion is again your own choice.
But I think Ashish has a good point. So
point for capital lunate fusion.
Because when this type 2 lunate is there, technically the lunocapitate fusion becomes difficult.
Yes, sir.
And even in the 4-corner fusion, you see half of the capitate is off the support.
Yeah.
So if we are faced with a decision where to choose between two and you are good at both, so this is one case in which we will little bit drift towards PRC.
But Sunil, you also had the proximal pole intact, right?
Yes, sir. The CT shows a lucency here, but it was intact as such. The cartilage shell was intact.
Okay. I mean, that can still be incorporated in any of your fixations.
Yes, exactly.
As an additional support in this case, when you have a type 2 kind of.
So the size of the screw looks like a culprit for fragmentation of the distal pole. Otherwise, probably we could have salvaged the scaphoid. It was just a hardware fixation failure.
If you see the screw, is this a removed screw or?
This is a removed screw, sir. I just kept it for comparison with what we use.
You actually see some metalloses there. So that's why I was worried about, if you leave them alone, these are the ones which will create a lot of problems. You see the metalloses starting.
Yes.
Yeah.
And what I went ahead was I did a proximal pole excision contradictory to what you said. And this was the only leftover piece of distal pole. This was also fragmented and went ahead with a 4-corner fusion after proper reduction of the mid-carpal joint and correction of the DC. And this was 4 months post-operative radiological result. And this is his outcome on his right side. A reasonably happy patient, occasional pain, but I think for the initial X-ray, this is a reasonably good result.
Pinurectomy?
I think when we open the capsule, it's done inevitably. So
that's a very good result for the range of movement you've got after a four-corner fusion.
Yeah.
Yes.
That range of motion defies all wrist biomechanics.
It does.
Probably that was his only, I mean, he's a policeman and that made him push him.
The site identification was correct, right? I'm just...
Yeah, I made it slightly look less bent here for you to identify it.
But damn good.
And my wrist does not have so much movement. That is nice.
Okay, thanks, Dr. Suneel, for your
thanks,
presentation. So we'll go with the next presentation by Dr. Ashish. I can start sharing your screen, Dr. Ashish. So Dr. Ashish is a FNB trained hand surgeon from Ganga Hospital. He's did his medical schooling from Ranga Raya Medical College and MS Ortho from Nizam Institute of Medical Sciences. From past 3 years, he's practicing as a hand surgeon in NRM Medical College at Vijayawada and Swara Hospital. So he has 4 international publications in hand surgery. So welcome, Dr. Ashish. You can start your presentation.
Thank you, sir. Thank you, Sathya and Krishna, sir, for giving me this opportunity. And again, thanks, Karnataka Orthopaedic Association. So I just want to present my case, like zone 4 flexor tendon injury. So this is an 18-year-old male who is a degree student with a right hand dominant, presented towards with a 1 week old sickle cut injury to the right hand at the wrist extending into the palm. So clinically, there is a loss of arc of finger stress, sensory loss over the ulnar artery, and intrinsics are not working. So I just want to go this. Most of the time, I never. After coming from Ganga, I have operated very less zone 2, and I operated more zone 4. So always I am getting a problem with zone 4. So I just want to present this case. So I make a diagnosis as 1 week old sickle cut injury, right wrist with extend ulnar aspect extending into the palm with zone 4 flexor tendon injury of ring and little finger with ulnar injury. So after exploration of the wound, the ulnar found divided and the zone, I just present a video. So this is the ulnar nerve, ulnar artery, and the flexors got divided. The index and the middle FDP and FDS is found divided at the zone beneath the carpal tunnel level. So this is the deep motor branch and this is the sensory branch. So I like to ask questions like, there is a pertained anatomy difference. Is it making anything difference to repair what suturing technique we use? So usually in zone 2, we are seeing the circular type of the good tendon, but in zone 4 and near the zone 5, all the FDP of index, middle and middle ring little has a common tendinous portion. It is very flat. Anything, all cases I am seeing the same anatomy. So anything in difference make what type of suturing technique we are supposed to use?
Dr. Praveen, sir, you want to take the question?
Hi, Ashish.
Hi, sir.
Yes, you're right. I think at that level, zone 4-5, the tendons become a little bit more flatter. So that is correct. But good thing is, there again, we don't require that much of smooth surface all around the tendon, that because there is no gliding tunnel in that area, no pulley system is there. So, but still the tendons are big enough to have a Kessler bite. So we would still take a Kessler and make it really strong, because at that place, even if a bulky repair is there, it is not an issue. We make it strong so that you can move it early. Force trend repair, and then put a circumferential tendinous repair also. But you are right, they are more flat, but still you can manage to pass Kessler suture through that, yes.
Okay, sir. Material, sir, is it Ethibond is preferred or Prolene?
Both are okay, but we use 3-0 Prolene.
We are supposed to repair FDS, sir, along with FDP, or we need to leave the FDS?
At this zone, both repairing is better.
Any significance of the ulnar nerve injury that can cause the functional outcome?
Yes, for this patient, actually, when ulnar nerve injury is there along with flexor tendon injuries, many times there may be concern that you repaired the nerve, whether you can move the fingers or no, but it is not an issue at all. We can continue the flexor rehab as such. But whenever ulnar nerve injury is there, since the patient would likely to develop a claw hand, this is one patient who we have to be very, very careful that he should not develop extension contracture at the MCP joints. So we would, from the very beginning, for initially anyway, he will be on a slab, and later on we will give a splint and knuckle bender splint. So all the time his MCPs should not get into flexion contracture. Otherwise, later on, correcting his claw deformity also would become very difficult if the ulnar nerve does not recover. And such patients very commonly develop this extension contracture because the flexors also are tight.
Sir, what position of the wrist we are supposed to maintain? Usually, they describe 15 to 20 degrees of wrist flexion after the flexor tendon repair. That is what all literature also telling for zone 4 and zone 5. But that is causing some adhesions of the flexor tendon to the scar tissue. So, what is the position of the wrist we need to maintain it?
I think around 20 degrees of flexion should be okay. Even 30 degrees is okay. More than 30 degrees we should not put. Then it will cause more contracture. Okay. I think 30 degrees of flexion is quite okay. Only difficulty comes is if you are in zone 3 and you have cut the carpal tunnel.
Okay.
So then it is quite tricky. So when you are in the carpal tunnel area, either you should not cut the carpal tunnel completely, or if we have divided, we have to divide it in a Z fashion. Or suppose we are not able to have any coverage for the flexor tendons at all, then it is better to immobilize in neutral position and not flexion of the wrist, because flexion of the wrist will cause bowstringing of the flexor tendons. And then everything will get adhered near to the skin. So then we would go for a neutral position of immobilization. Fingers can be flexed a little bit more.
Actually, in this case, the carpal tunnel found it has been completely torn off, sir.
Yeah, so then neutral position is better. As I think that's what you are thinking. No? So neutral position is good. Otherwise, it will result in some bowstringing of the flexor tendons.
So rehabilitation protocol, sir, is it advised to do an active flexion protocol or assisted passive flexion protocol?
Actually, at this level, the rehab need not be so much aggressive as we do for zone 2 repairs.
Yes.
But generally, patients, if we tell them to do passive movement also, they would be doing mild active. So I think passive flexion, place and hold technique would be okay for it.
Okay.
So we will passively flex and ask them to hold it in flexion. And if our repair is good, even if they are doing active flexion, I think it should be okay.
No. So I went ahead and repaired the flexor tendon, sir. I didn't repair the FDS here because the little finger FDS is very thin. So I can't able to get a good repair of the FDS. So I just repaired the FDP. And ulnar nerve, I have repaired both sensory and deep motor branch. Rehabilitation, I followed the same modified Durant's protocol. But I landed up with flexion contracture of BIP joint of little and ring finger with around 20 degrees of flexion contracture is there. And whenever I am stretching, the tendons got adhesive. So I went what wrong I have done. So the same problem, the flexor tendons. I followed all the techniques, the 4-strand modified Kessler I have used. But thing is, I didn't immobilize the wrist in the position of the what I asked you now, sir. I didn't immobilize the wrist in the neutral position. I made a wrist into mild 15 degrees flexion in order to immobilize it. So maybe the reason I landed it in the adhesion of the tendon. And one more I noticed, sir, all zone 4 and near zone 5 around the wrist cut injuries where the ulnar nerve is injured, their inability having the claw hand. So that claw hand, persistent claw hand is causing the PIP flexion contracture. How we can prevent that until the intrinsics recovered?
Yeah, so that's what I meant. So whenever this flexor tendon with ulnar nerve injury is there, that is Binu sir would also know much more than me because he is from the claw unit. So they have a lot of publications on that. But I think, and recently also I saw one paper which says that this flexor tendon, if tightness is there, that is the worst thing for the claw deformity to happen. So I think how we can prevent is from the very beginning, have one extension block to the MCP joint. Not too much, just about 20 degrees. And then stretch the fingers into full extension. PIPs should not be remaining flexed.
Okay.
Only MCP 20 degrees, and we have to stretch the fingers up like that. At 4 weeks itself, we should start nice stretching exercise. But MCP flexion of about 20 degrees should be maintained. It should not be much flexed also, because that again will shorten the flexor tendons further. So 20 degrees flexion at MCP joint and rigorous stretching of the fingers to get full extension at IP joints.
So I have done 3 major mistakes. One is I immobilized the wrist in flexion, and I didn't, what you said, sir, I didn't immobilize the PIP joint. I left the splint with PIP in flexion, dorsal blocking splint. It is not immobilized the PIP in extension. So there is a flexion at the PIP joint that resulted in flexion contracture of the PIP joint. So this is how I put the slip. I just left the fingers, so the flexion contracture is developing. So now I learned the lesson that whenever he is not doing an active flexion, passive flexion, whatever the exercise, we need to immobilize the fingers to the splint. We need to tie the bandage to the splint such that the PIP should lie in extension. So rehabilitation, such a lot of literature, sir. What is the best active versus passive? So after the thorough research, I came to know that active flexion rehabilitation is far better than passive flexion. So now I changed, using more 4 to 6 strand Kessler with epitendinous and started doing the active flexion. So in this case, all the problem I faced, so I went to do a tenolysis after 6 months. All the flexor tendons which got adhesed, I need to do a tenolysis. With a great heart that ulnar nerve, I didn't damage the ulnar nerve luckily during the tenolysis because everything is fibrous there. So I didn't know where the ulnar nerve is also located. So this is after the 9 months after the tenolysis, luckily the patient is very happy. He recovered the complete flexion and extension. The PIP flexion contracture is also lost. The intrinsics has been recovered. Even the Fomet sign is also negative. He can able to extend. The only problem he is facing is intraosseous are not working properly. Anything more we can get it during ulnar nerve repairs, because the adductor policies has been recovered. The Fomet sign has been disappeared, but still the intraosseous are not getting properly.
Dr. Binu sir, you want to comment to say what we can do to improve the intraosseous function?
There is no clawing, is there, Dr. Ashish?
Yes, sir. No clawing is there, sir.
Yeah. So, I mean, I think intrinsic strengthening exercises is what I should be doing.
Okay, sir.
And that should probably improve further intraosseous function. I think you have got a reasonable recovery of your ulnar nerve also. There is no clawing, and you have to accept certain amount of weakness following an ulnar repair at this level. So I think encourage the patient to do more intrinsic strengthening and abduction adduction exercises.
And one more problem is having, sir, sensory hyperalgesia, sir. We recovered the sensation, but it is hyperalgesia is persistently present even after 1 year now also. The same complaint, it is more painful compared to the opposite side he's telling. Anything we can do now to decrease the hyperalgesia? I thought it will subside in due course of time, but it is not decreasing at all.
These are all problems inherent to any nerve repairs.
Okay.
And surgically, if you consider, the only thing that can be offered is a neurolysis, and we are not sure how well that will change the hyperalgesias. But I think, sometimes if it is very severe, we do offer them a neurolysis, and some patients do improve with that.
I think I want to comment on this hyperalgesia. I think, Ashish, luckily somehow in some of my patients, I was able to get over with some sort of desensitization techniques, which I keep them, teach them myself and ask them to continuously, keep touching the sensitive areas with different sort of materials and keep on desensitizing them. So probably in 2 of my patients, I could get over with desensitization techniques, but I don't know how far these techniques will work for everybody.
Okay. Thank you, sir. After the learning, I am doing a 6-strand Kessler now, trying to put more strands and started the active flexion, doing all FDS and FDP. And even we can get I can able to get the individualized FDS function also. So lesson learned is we should not immobilize the wrist in flexion whenever we are releasing the carpal tunnel, whatever it may be. Thank you, sir.
Thank you, Dr. Ashish, for sharing your experience. Dr. Binisa, you just said that I also have a lot of this patient, they don't have ulnar claw, but they complain of intrinsic weakness. So you're saying that just to ignore that, or is there something we can do to improve the intrinsic function?
Intrinsic function, intrinsic exercises are there. That is what.
In spite of that, they don't
available. Then sometimes you have this Wattenberg sign where little finger abducted, and
so apart from that, they're just worried about the index, middle, and ring adduction, abduction. That's their main concern. So you ignore that, or there's something you suggest we can do?
Theoretically, it is possible by doing, intraosseous insertion for the claw correction procedures to provide adduction, abduction. But I have not actually done for any patient who has really complained. I have done for the little finger abduction, I have done the Kleinert Blacker procedure with quite a lot good improvement, because that's a very difficult thing. If your little finger is sticking out, and whenever you open a door or put your hand in your pocket, that tends to get stuck or injured. So that is the problem.
Dr. Anil sir, what do you say? You also ignore it, or do you do something about it?
Finally, it's based on the disability of the patient, right? So if it's really bad for the patient to do, is even one of the things they complain is they can't mix the rice, and they can't eat well if it's especially a dominant hand. And as Binu was telling, theoretically, one of the procedure is the intrinsic substitution procedures, Dr. Srinivasan's procedure, where it's more of a static kind of a transfer. So where the tendon grafts are used, and then you can get some amount of adduction, abduction coming in. When Dr. Sridhar has described, I think, one procedure where you can do an intrinsic substitution procedures. So those are available, but you need to quantify the disability and then only go for these kind of things, because rehabilitation of these will be quite tough. Because this will be more of static procedure. It won't be a dynamic kind of procedure.
Thank you, sir.
Next. At 9 months, we need not rush to do any of these corrections. His result, as far as, since the claw is not there, so getting an operation so no tendon transfer is going to give him adduction and abduction for sure. And it is only 9 months. And as Binu sir told, if we put him on intrinsic exercises, he should improve with time. 9 months is a little early to do transfer for just adduction and abduction.
Not about this case.
Since flow is not there, it is already a good result, and you need to only do exercise, no surgery at this stage.
Okay. So thank you, Dr. Ashish and Dr. Praveen. So next we have Dr. Ajeesh. Ajeesh, you can share your screen. Dr. Ajeesh Shankaran is currently a consultant hand and microsurgery at KIMS Al-Shif Hospital, Perinthal Manna in Kerala. So he did his medical school and ortho from Vamsi Maulana Azad Medical College. He's FNB trained from Ganga and fellowship in hand surgery from Climate Institute, US. So he's going to present a case on infective claw deformity. Go ahead, Dr. Ajeesh.
Yeah, thank you, Dr. Vamsi. So thank you for the opportunity for OASIS, KOA, and Vamsi for allowing me to present this case. So there were some, I guess, special features of interest, maybe a lot simpler than the other cases presented today. And then some elements of suboptimal management which make this case interesting. So the patient was a 17-year-old male who was a non-resident Indian. He does his schooling in one of the Emirates and had a clawing of the dominant right hand, small and ring fingers, and numbness tingling in the small finger. And he was referred from our orthopedics department for an ulnar nerve repair. And the history was that there is a query history of fishbone injury to the palm about 2.5 months ago. Patient is not so sure if that has actually ever happened. But the story is that there was an abscess in the palm, which he underwent multiple serial debridements in the Middle East. And these debridements, the thrice done under local anesthesia. They were daycare and with oral antibiotic coverage. And then over the course of this, I think that this was over a period of around 1 month, the patient developed the current deformity that he had. And finally, there was one procedure which was performed in regional anesthesia, and where a biopsy was performed, which had a soft tissue and a bony component to it. And it's at this biopsy that things actually begin to get a bit confusing, because this biopsy from done elsewhere, it says that osteosarcoma cannot be ruled out. And at this stage, the patient had enough and then came back to Kerala. And he actually did not have the earlier X-rays, but he had the biopsy slides and the report with him. So this was at presentation. Well, there's definitely a claw-like deformity of the small finger and to a certain extent to the ring finger as well, and a heel scar in around what is the fourth web space in the palmar aspect. And these were the X-rays, and looking at it closely, the fourth metacarpal, there's definitely a bony overgrowth, and you could make an argument for a sunburst appearance as well on X-rays at presentation. So, the diagnosis again from our orthopedics department, what it initially looked as was that this was an ulnar nerve injury. The whole question is it that actually that obvious? So the idea that this is actually not an ulnar nerve injury, and the patient actually had paresthesia on only the radial side of the small finger, and rest of the sensitive examination was actually near normal. A static 2PD where I'd measure on the small and the ring finger showed that it is the radial side of the small finger, there was definitely a difference, but others were more or less near the normal range. And more importantly, the first dorsal interosseous, the adductor pollicis, and all of them actually had normal part. So what realized over the course of the clinical examination was that this is not an ulnar nerve injury, but this is just that the intrinsics of the fourth web space have been destroyed, and that is what probably has led to this severe clawing. And while this seems quite innocuous, obviously we know that the claw is quite debilitating, and this is actually a video of the patient trying to make a fist. And we can again notice that Wattenberg sign is also present. Again, in the picture on the right, the patient is actually trying to bring all his fingers together, but the small finger sticks out. And while that again does not seem to be of any importance, but patients, and again, since this was a young chap, his parents were very concerned about this abduction deformity as well. So our plan was to first get a biopsy slide review with the help of our senior orthopedic surgeon. We were actually able to send it to the regional cancer center, and some sanity prevailed, and it came out that malignancy is unlikely and close clinical observation is all that is recommended. So since I already knew that this was not an ulnar nerve injury, we just went ahead with a claw correction tendon transfer and use. The plan was to actually explore the area, and if the FDS of the ring was okay, then to use it. Otherwise, to just go ahead with using the FDS of the middle finger. did a standard tendon transfer to the lateral band. And that's an intro picture of the FDS ring, which I found to be okay, and that has been delivered. Those other two FDS strips delivered to the dorsal side of the finger on the adjacent sides of the fourth web space. And the patient had a good result. So at 9 months follow-up, even I think the Wartenberg sign had corrected to a certain extent, certainly not fully, but certainly a more functional hand than before. And the X-ray also, once again, obviously clinical and radiological follow-up, we continued at 9 months. We found that the bony overgrowth had begun to decrease. So we just continued following up further. That is the plan for the next. So the points to think about were, for a palmar abscess drainage, probably is something that is better not attempted under local anesthesia. That is what I felt, since any attempt at any incomplete drainage in this area with the tendons, the muscles, and the nerves being in close proximity, any incomplete procedure in this region is probably likely to end up with a severe, devastating deformity. The other was obviously a careful clinical examination. It was quite easy to end up with just exploring the ulnar nerve, finding a negative exploration, call that a neurolysis, and just keep waiting for recovery, and probably which would never have come. And obviously regarding the biopsy would be to consider the picture in total, not just one report of the biopsy. And of course, again, one keeping the medico-legal issues in mind, since the diagnosis of a malignancy is not something that could be taken lightly, and therefore we went to one of the highest possible authorities regarding the pathology, and so that could be comprehensively ruled out. So thank you for the opportunity. That was a pretty quick presentation. I would just love to hear what the panelists have to say about the case.
Thank you, Dr. Ajeesh. Dr. Praveen sir, you want to comment?
Yeah, it is quite nicely managed, Ajeesh. Very, very good result also. So only thing I was thinking, the MCPs initially looked very stiff, but still you have got a very good result. So that is a very nice outcome and very perfectly managed. This is because of the loss of interossei, I think, because of the local infection, there would be necrosis of this interossei. That is the same thing what happens in transmetacarpal replants. Now, when we are doing replant, we remove the muscle. So all of them also develop claw deformity. So it is because of that local loss. And as you rightly picked up, so the nerve was intact because sensation is there. And since sensations are good, it is very logical to straight away go for a tendon transfer in a young boy like this. And FDS for 2 finger would work perfectly. Well, nicely done.
Thank you, sir. Dr. Anil and Dr. Dinesh, you have anything to say? Or should we go with the next case?
I think.
What were the exact intra findings?
So I can get that, sir.
No, what were the exact intra finding?
Yes, sir. So we did, like sir said, there was actually a loss of the musculature in the fourth web space. The nerve was actually intact. I didn't really go out further, but only in the area of the fourth web space. The nerve was actually in continuity. So, and there was no signs of any infection. That will probably settle down as well. So, and even clinically, it didn't look like any of the infection component was still, still persisting before we went out with the tendon transfer.
Okay, I was a little worried with the periosteal reaction and everything.
Yes, sir. That's
exactly for the osteomyelitis part. That's
right, sir. Okay, so the osteomyelitis, there's nothing. Yeah, the metacarpal, I just found out this. There's nothing that looked infective. There's definitely a widening and maybe something, what would you call a periostitis sort of a feature, but nothing which looked frankly infective at the time of surgery.
Okay.
Because there was actually a question of should we send a repeat biopsy? Should we send a repeat biopsy when you're doing it again? So, but
I mean, that would be the only deterrent for me for the tendon transfer part, yes, where the bed itself is scarred, and then there could be the periosteal reaction with the osteomyelitis possibility. Otherwise, yeah, what you've done is great.
Yeah, I think that's a lesson learned is osteosarcoma, osteomyelitis can mimic how periostitis can mimic osteosarcoma, and judiciously we have to consider work it out.
But,
Yeah. Thank you, Ajeesh. Next we have a case by Dr. Gopinath Bhandari. Dr. Gopinath is a consultant hand surgeon in Apollo Hospitals, Hyderabad. He's done his PG from Manipal and hand surgery training from Ganga Hospital. So Dr. Bhandari is fortunate to be having been worked with Dr. Anil Bhat sir and Dr. Praveen sir. So after his fellowship, Bhandari traveled to Spain for wrist arthroscopy fellowship and has also presented research papers in World Microsurgery Congress at Italy. Dr. Bhandari, apart from being a hand and microsurgeon, is a sand artist. I think there are a lot of his videos in YouTube. People interested can have a look at it. Dr. Bhandari, welcome, and please go ahead with your presentation. Dr. Gopinath, are you here? Gopinath.
Yes. Am I audible to everybody?
Yeah, now we're audible.
Yeah. First of all, I'd like to thank Dr. Vamsi for giving this opportunity and also OASIS for giving this opportunity. And it's proud to share space with all of you here. I'll straight away go into the case. I think this is probably one of Binu sir's favorite case. So, management of mismanaged PIP fracture dislocation. I had a 28-year-old gentleman who was a police constable. 3 years back, he had a cricket ball injury to the right middle finger. He had mallet deformity. Because he just had a deformity and clinically, functionally, he had no problem. He just ignored the deformity of the right middle finger. Again, 6 months back, he had another cricket ball injury this time to the ring finger. And this time, the X-ray, when he presented to the initial surgeon, this was the initial X-ray. So he went elsewhere and he presented with this X-ray. And clearly we could see that there is a bony mallet non-union with mallet deformity and also a PIP fracture dislocation of the ring finger. So he presented to some other surgeon with this X-ray. And clearly we can see PIP fracture dislocation here. And he was operated at 3 months by capsular release and K-wire fixation of the PIP joint and also extension block K-wiring and anchor sutures application. This was done elsewhere. And we don't have any X-rays or any other thing related to that fixation. So even after this fixation, he tried physiotherapy for a few days, but he did not get any improvement. So at 6 months after the injury, he came to me with this X-rays. In these X-rays, we can clearly see that there is a suture anchor at the middle finger, and the non-union of the bony mallet injury is still persisting, and definitely mallet deformity is still visible. But still, he is not bothered about middle finger because functionally it is not limiting, and the ring finger PIP dislocation was still persisting, and he had complete stiffness without any active range of motion in the ring finger PIP joint. So this is what he presented to us at 6 months of injury. So I think probably we can take the opinion of Binu sir or Praveen sir. Now his problem is only ring finger PIP joint, 6 months after injury and operated by capsular release and K-wire fixation elsewhere.
Mm-hmm. So he wants a full range of motion at the PIP joint also.
Yes.
Mm-hmm. Okay. What was the approach for the previous surgery?
It was a volar approach, sir.
Volar approach,
we can clearly see the Brunner's incision here. Mm-hmm. And this was the again incision for the middle finger mallet injury.
Yeah. We have to really study the lateral view of the finger and see, because at this level at 6 months, whether there is sufficient cartilage to do any kind of salvage procedures where you can provide a movement is, that would be the key to what your management will be. So our options are, of course, we know that, the volar plate arthroplasty and hemihamate is an option to provide a mobile PIP joint. But at 6 months, many times you see that this, especially with some intervention already happening, the remaining cartilage on the head of the proximal phalanx may not be there. Plus, you see that persistent dislocation with the V sign and everything. And even that cartilage may be very flaky when you try to put in a osteochondral graft or something. Whatever cartilage on that side also may go. So you have to get the consent from the patient that in case of that, we will have to do a PIP fusion. So having said that, I have done PIP, hemihamate arthroplasty in patients more than 6 months also successfully. So I would keep my options open here. And one more thing, there is another operation which I've been trying to, kind of promote. That is that volar plate interpositional arthroplasty. It was described by one guy called Lin. So where you actually excise the arthritic head of the proximal phalanx and put the volar plate right onto the dorsal lip of the middle phalanx. So I found reasonably good results. Range of movement is good, and even long-term results have been quite satisfactory. So that would be another option other than PIP fusion. So if I am thinking about any surgical intervention, I would keep my options open, discuss with the patient that there is a chance that some of these things may not work and you may end up with a fusion, or try for this. So that would be how I would tackle this.
Thank you, sir. So exactly as you said, and frankly, this was my second hemihamate only. So, and it was already operated. I was expecting a lot of fibrosis, and I was actually a little scared to go in, but somehow I had to go for the case. And I have counseled him also regarding both options of volar plate arthroplasty or hemihamate. And definitely, if nothing works out, maybe he may need a future of PIP fusion. Everything after all the thorough counseling, I have taken up the courage to go ahead and do a hemihamate arthroplasty. And intraoperatively, we can see that there's a huge gap in the base of the middle phalanx with a malunited condyle here. So I have taken a small matchable joint part of the hemihamate and fixed with 2 screws. And this was the intraoperative picture showing the fixation with 2 screws and a good range of motion during the surgery. One thing which I was scared of during the after fixing was that I felt this condyle which I have fixed was very large. That's what I was having in my mind after fixation, and I didn't want to take it back again and trim it and put it back because I feared loosening of the fixation. And I was just thinking that this huge chunk which I have placed may interfere with the flexion. But luckily, I was lucky enough again, and at 4 months, he has a very good flexion at PIP joint, and all the movements are restored. And definitely, ring finger had the mallet deformity still, which we did. He was not interested to get corrected. Any comments after the fixation, seeing this fixation?
I think that's an excellent result for a very difficult PIP joint case. And even I have noticed that when you put these hemihamate, sometimes it does stand proud, but as long as your passive flexion is full, you don't need to worry about that, because it's the way you've shaped your articular surface, it is quite congruent, and then you will get a full range of motion. So I think this is fine.
Praveen sir, any comments?
This is quite nicely done. So it is come out very well also. I think this is a good indication for doing a hemihamate. And since the head was having good cartilage, it was a nice indication.
And,
so one to you and to Binu sir and Bhat sir. Sir, in case you find that the head is not good, do you think volar plate arthroplasty would adjust better than the hemihamate osteochondral graft?
I had that in my mind.
The cartilage head is not good. So in those cases, you feel like volar plate would adjust better than putting an osteochondral graft?
I had one patient whom I did on hemihamate for a patient whose cartilage was flaky in the head. And initially, the movement was quite good. But he came back about 9 months later when the PIP joint had fused by itself. So this is one experience I had, and this guy was a dentist. So it was not that he was not moving and all. It slowly over time just fused because that cartilage got worn off, and so it was a fusion. So this is what my worry is when I see nowadays the cartilage not being there when you do a hemihamate. So in those situations, a volar plate may fare better, but it is with all the resultant instability which you may have.
Mm-hmm. Yes, sir. Actually, even many of the patients with stiff finger, when you do extensive arthrolysis, tenolysis, initially they look good, and we have seen that cartilage is not good inside. So immediately they will start moving nicely, but very quickly in few months itself, the arthritis comes in.
Arthritis comes or it goes into fusion.
Yes.
Yeah.
So would you straight away go ahead with the volar plate arthroplasty for such cases also, sir?
This looks okay, Gopi. This here, the cartilage looks quite nice. I think this is a good one to do hemihamate. You've done it correct. Nice.
I was just having in my mind whether I shifted from a posterior V sign, dorsal V sign to an anterior V sign looking at this X-ray. But luckily, my movement, the result was good at 4 months, so I was happy about it.
Is there anterior V sign?
No, it looked like anterior
no,
V sign.
There is nothing like anterior V sign.
It looked like that.
No, because the stability comes from the dorsal
congruity, I think.
So there is no anterior V sign. In fact, this is good because here that small step and V, what you see is because of the thicker cartilage on the hamate.
Yeah.
So in fact, that is not inside. You may not have that type of gap. How much you are seeing in the X-ray? It's nicely done.
Thank you, sir. Quickly, I would like to present a small second case. So this was a 22-year-old gentleman. He runs a business of printing press machine. So while he was operating once, when his labor was not there, he accidentally got his hand crushed in the machine. He was not used to this job, but because his labor was not there, he had to do that. And he presented to me after 6 months after the injury. He was operated elsewhere by K-wire fixation. So this was the initial picture which he sent to me on WhatsApp. He also had a web burst injury with all the adductor muscles and the web space muscles popped out through the web space. So this was the initial picture at the time of presentation. He had a thumb first metacarpal fracture and also a CMC fracture dislocation, which was not noticed by the initial surgeon. And he had considered it probably as only a base of metacarpal fracture, and he went ahead with metacarpal fracture, base of metacarpal fracture fixation along with the thumb fracture fixation. So any of you would like to comment on this fixation, sir? This was done elsewhere by another surgeon 6 months back at the time of presentation.
CMC is commonly missed because people tend to miss out to get a lateral view X-ray.
Correct.
The mistake, I think, is the first thing to be done when you are suspecting a CMC dislocation.
And anything about the thumb fixation?
So it looks like a linear, overlapping all the joints.
The super wire, right?
Actually, they should have put one more wire maintaining the first web.
Yeah,
So much
that
wire
would
they
have
have done.
probably
That is the
prevented.
best wire.
Yeah, like a suspension wire. But unfortunately, they have not put. And when he presented to me 6 months after injury, this was the X-ray. The wires were removed by the initial surgeon. And I got a lateral X-ray which clearly showed a CMC fracture dislocation. And the thumb also has gone into, first web space also has gone into contracture. He had absolutely stiff fingers without any movement at the stiff fingers. Wrist also was very less mobile. And thumb was very stiff because of that super wire which was crossing all the joint. So hardly he had any movements. So we got a CT and clearly it was showing all the second, third, fourth, fifth CMC joints fracture and dislocation. So initially I went ahead and opened in a dual approach, polarly and dorsally, and used K-wires to transfix the CMC dislocation. That time, actually, I teached him stretching of the first rib space, and I taught him some exercises so that he can stretch out the first rib space gradually. And because his metacarpal was almost uniting at that stage, I didn't want to go again and fix it. But later, after 2 months after my CMC fracture dislocation fixation, I have seen that his thumb CMC joint has completely become stiff. The metacarpal was completely adducted, and the movement which was happening because the metacarpal head was completely in a mal-aligned position, and it fits in a bad position so that the thumb was only the MCP part of the thumb was sticking out. There only he was able to do certain movements. So definitely he was not able to oppose, only it was sticking out like that with the first metacarpal completely adducted. So this was the picture. This few days, just about 15 days back, I have operated again by doing a first web release. I did a 5 flap Z-plasty for the first web, and there was complete fibrous tissue filled in the web space, and I didn't see any muscular tissue. And also I did a thumb also was in a the base of the metacarpal was also in a bad shape. So I wanted to mobilize him quickly, so that's the reason I plated it instead of choosing K-wires. And this is about 3 weeks after the thumb surgery, first web release. These are the movements of the fingers and the wrist. And after 6 weeks after the first web release and CMC mobilization, this is the position. Now he is able to get up to Kappanji score 6. Finger movements and so anybody would like to comment anything, sir?
Dr. Mandari, regarding the CMC dislocation, it's very difficult to get the reduction. So what was your sequence of surgical steps? So please elaborate.
Yes. Firstly, I went ahead dorsally. I tried to expose all the dorsal structures and clearly identified the dislocation, opened up the capsule there. And I tried for a reduction without opening volarly. But of course, on the fourth and fifth CMC joints, I was able to reduce without any much problem. But the second and third CMC joints, I was not able to get a good reduction. So I thought I should probably try a volar approach. But getting a volar approach was difficult at that area. I was not quite sure about it. So I thought I'll have an extended approach. I retracted the tendons, I retracted the median nerve, and somehow I had to, I juggled to get through that path. And so a little part of the base of the CMC joint I nibbled where the fracture loose fragments were there. Those parts, the second and third metacarpal bases, I nibbled. The loose fragments I have excised, and then somehow try to push it in with a little difficulty, and then my K-wire could hold it good in a good way. So yeah, that's it.
How many months after injury is this?
This is 6 months after injury. He came to me 6 months after injury. This one.
Because it's so difficult to reduce that we tend to fuse it off. Anything more than 3 months old CMC fracture dislocations, we tend to fuse it off. We are very lucky to get that good reduction.
I think fourth and fifth, I was able to get it without any much difficulty, and maybe that did not go into that may not go into fusion. But the second and third, because I nibbled the base articular cartilage and removed the fracture fragments, probably that would eventually end up in a fusion there. Second and third metacarpal bases.
Dr. Praveen sir, what approach would you prefer in neglected cases? Is it transverse approach or a linear approach dorsally? Because Dr. Bandari uses small approach dorsally, but I feel it's very difficult to visualize all the CMC joint. I mean, my personal experience.
I think this is the approach is actually extending till here.
What was it? Okay.
But somehow his scar is not seen here. It is a long approach. It is not a small approach.
I think this also is quite extensive if you put it like that. I would go with 2 incisions, one between the ring and little, and one between the index and the middle. So with the radial one, you get good exposure of the index and middle finger CMCs, and from the ulnar one, you get these 2.
So why not a transverse incision, sir? Why not a transverse incision to see all the...
Yeah. So here, I think at 6 months, transverse incision is not a nice thing because you are going to increase the length, no? So the suture could become tight. When it is a longitudinal one, it is better. I think so. Because transverse ones, especially when we are going to move immediately, they tend to stretch out, and there is always a fear that it is going to stretch out. But when you put a longitudinal one, it is quite okay. And when you are doing at 6 months, you will require a lot of mobilization proximally distally. I think 2 longitudinal, one on top of the index finger over here, where we can go to the second and third CMC, and second one in between at the 4th web space. So 2 incisions should be okay. I have not done any time from the volar side. We have not gone any time. But I think at 6 months also you can get them reduced, and we should try to get reduction to the 4th and 5th at least. 2nd and 3rd, even if we are fusing, okay, but 4th and 5th CMC we should avoid fusion.
Why, sir?
We should get it because those are the ones which are mobile part of the CMC joints, and that is the one which is going to allow a nice grasping of the anything in the hand. Because the 5th metacarpal need to flex nicely to hold on to small things. So 5th one we should try to get reduced, not fuse it.
What I find is that the ECRL and ECRB are very taut. They never let you come down. So
so that's why you fuse the 2nd and 3rd. So you tackle the force of the ECRL, ECRB.
So you mean by fusion, you need to shorten the base of the...
you just shorten it maybe half centimeter. That should
How about the ECRL, ECRB attachment? So that you have to sacrifice now. So if you want to shorten the metacarpals, you have to sacrifice the ECRL and ECRB. Yeah. So how do you avoid that?
One thing is ECRL, ECRB have little bit more wider insertion. So it allows removing around 2 to 3 millimeters. And you could remove on the proximal side as well. So it is okay.
I think in my experience, the 2nd and 3rd metacarpal bases, though I had to remove, but definitely as sir said, I didn't face any problem with the tendon insertion. I didn't. There was no need of sacrificing any of the tendon insertions.
Tendon is little wider insertion on the dorsum, so you can a little bit scrape it and remove maybe quite easily 2 to 4 millimeters. We can remove.
Vamsi, can I come in?
Yeah, please. What else, sir, you can comment on the CMC dislocation?
Yeah, we have published a couple of cases with all the CMC dislocations, and we have used transverse incision. And that gives an opportunity for you to see what happens basically is, if you look at the X-ray of this patient also, the 2nd CMC is pushing the thumb away. And if you don't reduce the 2nd CMC, the thumb is always subluxated out. And that's what happens here also. So there is no space there for the 2nd and the 1st to sit nicely. So that is very crucial that you reach out. And again, as Praveen also told, we have never gone on the Olar side. It's very difficult to go to CMC on the Olar side. And so a lot of soft tissue disruption happens and can lead to contractures and web space contractures. So the best would be a dorsal approach, either 2 or I've always gone with the transverse incision because I can reach all the joints in one single incision. And when patient mobilizes also, it goes along the skin crease, so it becomes easy for the patient to mobilize. And you basically go down the dislocations because there will be a lot of fibrous tissue. It's very difficult to identify the joint surface, the cartilage, and you might end up damaging the joint surface very easily in these patients because there is a fracture surface and then there's a very small joint space. So you starting with the fifth, you need to go one by one. Once you reduce fifth, come back to fourth, and then only the space comes. Otherwise, you can't do this. So finally, you reach the second one, and it's very crucial that you reduce that second one. If not possible, really it's damaged, then you just have to do something like an excision arthroplasty there, which will lead to fibrous union and give some movement. And one more thing, as you rightly pointed out, the ECRL and ECRB can shorten very strongly a myoelectric kind of contracture, and that can be solved by a partial excision of both the tendons, and then you start getting some play, and then it becomes easy for you to reduce. So we really don't have to go and nibble out things there and then fuse that. But once you release the soft tissue, the joint comes back. The more important one is the joint with the soft tissue contracture there. And that is when the thumb will come back and sit nicely. Otherwise, the first CMC joint doesn't have much place there because it's sharing the articular surface there, and the trapezoid is such a small bone there. So a second CMC reduction becomes very, very crucial. The third one probably can be left alone. But for you to get a good thumb movement, the second CMC joint should be reduced well.
Thank you, Dr. Anil, sir.
So one comment I want to make is that, volar approach, Dr. Bandari, it's quite risky in the sense the deep branch of the ulnar nerve, especially in that scar, you may not find here. Probably are okay because the crush has taken out the adductor pollicis and all those muscles. But otherwise, you will end up with a kind of claw deformity. So that's why nobody has advocated a volar approach for CMC joints, I suppose.
Most of the patients have good range of motion. They just complain of the bump. So one patient that just exercised the bump and he was satisfied. I'm not sure how good it was. I mean, it was a good technique to do it or not. But they have excellent range of motion, these people. Any comments? I mean, you have any similar experience?
Yes, Vamsi. Actually, if we see biomechanically and functionally, CMC joint injuries will invariably give good result, because CMC joint, except for fifth one and the first one, of course, they don't require much mobility. They only require stability. So even with dislocation, if that bump is not eroding onto the extensor tendons, they would be having okay result. So if we are seeing such a patient, what Gopi has presented at maybe 2 years, at that time, either all the tendons would have gone for myostatic contracture. At that time, bringing them to correct position is not a good idea because it can cause some stiffness. For such case, you can just shave off the heads. Think it may be okay for 1 or 2, not for all 4.
Sir, I'd like to ask a question, sir, regarding this. Luckily, Gopi has a dorsal dislocation. Recently, I came a patient with volar dislocation of 3 months old neglected volar dislocation. Dorsal, I think they don't have rotational malalignment, but in volar isolated 2-3 dislocation, the patient has a severe rotational malalignment of the fingers.
Ashish, you are only the champion of CMC dislocations.
Yeah, I try.
Actually, Ashish only has assessed our CMC dislocations. We had some 50 cases, I think, and we have published that also. It was a very nice big series.
So the volar dislocation has this radial pattern, sir. That's what we have assessed at that time. So because of this radial pattern, the metacarpal arch is lost. So even I reduced the 2-3 dislocation also, the rotational malalignment has not been corrected. Maybe because of intermetacarpal ligament tightness because of long duration. How can we deal with that, sir? Any rotational osteotomy required at the base of the PPX? I don't know how, just I left it after reducing the CMC. I told the patient will review after 2-3 months once you get the complete range of movement. Intraoperatively, I thought doing a rotational correction osteotomy, it is very difficult.
One of the key fixation would be actually to fix it axially instead of transverse or across wires. So the more important way fixation should come through the metacarpal into the carpus. That is what will prevent the rotation with an kind of an oblique wire. So you need to have two wires to come in, one through the medullary cavity and one oblique wire transfixing the joint. And volar will go rotation because there is more space for the metacarpal to rotate compared to a dorsal kind of dislocation. So when you reduce that back, you have to have both control, both the axial control and the rotational control. So your K-wire should run through and through all the way. You can put from the head of the metacarpal, come down and withdraw it back into the carpals so that MCP is free. That is one way of doing it. And also put a cross K-wire for the CMC joint per se. So you need to have a dual control there. And keep it for 6 weeks. Even if it becomes stiff, you don't worry, but the reduction will stay after that.
Sir, it is not because of any intermetacarpal ligament contracture because of persistent volar radial dislocation.
No, not necessarily, unless it's damaged the interosseous muscles also when the dislocations happen. Right, so you have the metacarpal jutting into the buttonholing into the interosseous muscles and everything. It's got more space there for the volar dislocation.
Yes. Now, how can we manage it, sir? I tried the intramedullary wire and cross K-wire, but the rotation malalignment has not been corrected at all.
If it's at the base, the deformity is obviously it gets 3 times multiplied for your rotational malalignment at the finger level, right?
Okay.
So all you need to do is to see whether just a soft tissue release is enough, because you should not be causing a reverse deformity by doing a corrective osteotomy, because it's not a fracture.
Okay.
Yeah, so that way you should be very careful to assess where is the deformity and is it, because if it's a fracture malunion, it's very easy to check for the cora and then correct it for a corrective osteotomy. Here it's not so. The metacarpal is completely intact, correct?
Yes, sir. 1 minute, can I share my video, sir? I just want to show the clinical image of that patient, which I am telling multiple CMC dislocation, volar dislocation.
Did you actually fix it with a transverse intermetacarpal K-wire or transmetacarpal K-wire?
Sir, is the video is audible, sir? Is the patient, my screen is visible?
Seen.
Yeah, visible, yeah.
So this is the patient, the clinical picture, sir. So there is a severe rotational malalignment of the index and middle. So I can able to reduce the CMC dislocation, but the rotation malalignment has not yet able to correct it. So intraoperatively, I thought it because of any loss of metacarpal arch, persistent loss of metacarpal arch. Anyway, I will come back to you, sir. Once again, I get the complete images.
I think a latest X-ray would be better to see what exactly is happening.
Okay.
This is not giving us any clear idea why there is a malrotation.
Okay. I will come back to you, sir. Yeah.
Okay. Thank you, Ashish. I think we can end the program here. So Dr. Anil Bhat will do the closing remarks. And I thank all the panelists and presenters for joining this webinar. Dr. Anil, sir, you can go ahead, sir.
Yeah. Thank you, Vamsi. I think it's been a wonderful learning experience for all of us. I thank all the office bearers of OASIS who are still with us, Dr. Selvaraj, Dr. Aneen, Dr. Nithyanand Rao, Dr. Ashwini Kumar, Dr. Bharat, and really proud that KOA could do this as a part of the OASIS ICL. And with such wonderful faculty and all the colleagues who've given us so much of learning experience, I think this was a very good program for us. And also thank all the hard work done by Vamsi to put all this up, to put all of us together and all these very interesting cases. And also the OrthoTV for their technical help. Thank you so much and have a very good night.
It's Clarnet.
Thank you. Thank you very much.
Thank you, sir.
Thank you,
It's
sir.
Clarnet.
Thanks to Clarnet also for providing the Zoom platform. Yeah, thank you.
Thank you.
Thank you all for the great show.
Good night.
Thank you.
Good night.
Thank you. Night.
Good night, everyone. Thank you.
Good night, sir.
Thanks
Good
for
night,
Night.
everybody.
Thank you.
So we are closing here.
Yeah, thank you.
Yeah,
thank you,
so
Debalina.
much. Yeah, thank you, sir. Thank you so much.
Recording stopped.